The man sitting across from the neurologist does not look afraid. He does not look uncomfortable. He is smiling, actually, a loose, open smile, the kind you might see on a child who has just discovered something interesting on the ground. He reaches across the table and picks up the doctor's pen. He turns it over in his fingers, then puts it in his mouth. The doctor asks him to return the pen. The man looks at her with no trace of embarrassment, removes it, and sets it down. Then, a moment later, he picks up a paperclip and puts that in his mouth instead. His wife, seated beside him, has stopped crying. She cried for 3 weeks. Now she just watches. She says this is the hardest part. Not the early days when everything was chaotic and terrifying, but this. Sitting in a quiet room with a man who has her husband's face, who answers to her husband's name, who has no idea that anything is wrong. Her husband was 41 years old when a virus entered his brain. He survived it, but the person who survived is not entirely the same person who fell ill. The illness took something that does not have an easy name, something that most of us never think about because we have never had reason to. It took his fear. It took his disgust. It took the invisible wall that exists between an impulse and an action. And in the months that followed, his family would learn in the most intimate and exhausting possible way exactly how much of a person lives inside those things. Kluver-Bucy Syndrome is named for Heinrich Kluver and Paul Bucy, two researchers who in 1939 described a remarkable constellation of behaviors in rhesus macaques following surgical removal of both temporal lobes. The animals became placid where they had once been aggressive. They approached objects and other animals without hesitation, without wariness. They placed everything within reach into their mouths: food, inedible objects, other animals, in what the researchers described as a compulsive oral tendency. They displayed what appeared to be indiscriminate sexual behavior, and they seemed incapable of recognizing the emotional significance of what they encountered. A stimulus that previously provoked fear produced no reaction at all. Kluver and Bucy called this psychic blindness. The formal clinical term today is visual agnosia for emotional significance. In humans, Kluver-Bucy syndrome presents with a remarkably similar profile. The core features are 5 in number. First, hyperorality, a compulsive need to explore the world through the mouth, placing objects, sometimes including dangerous ones, between the teeth or on the tongue. Second, hypersexuality, disinhibited and often contextually inappropriate sexual behavior or verbalization. Third, visual agnosia, an inability to recognize the emotional meaning of faces, objects, or situations, even when basic vision is intact. Fourth, placidity, a flattening of fear responses, anxiety, and aggression, resulting in a temperament that can appear calm but is functionally dangerous. Fifth, dietary changes and hypermetamorphosis, an irresistible urge to touch, handle, and examine everything in the environment, often combined with compulsive eating or mouthing of non-food items. In humans, the syndrome is extraordinarily rare. It requires bilateral damage to the amygdala and adjacent temporal lobe structures, both sides simultaneously. It has been documented following herpes simplex encephalitis, traumatic brain injury, stroke, Pick's disease, and other conditions that produce diffuse temporal lobe destruction. Because the damage must be bilateral to produce the full syndrome, and because the amygdala is not a common site of isolated injury, true Kluver-Bucy syndrome in its complete form is seen in perhaps a few hundred documented cases worldwide. Daniel's case was one of them. Before any of this, Daniel was a high school history teacher in a mid-sized city in the Pacific Northwest. He had taught for 14 years. His students described him the way students describe the teachers they remember: patient, occasionally funny, someone who cared whether you understood. He coached the junior varsity cross-country team in autumn and spent his summers doing trail maintenance with a local conservation group. He was, by every account, a man of routines and small devotions. He woke at 5:30. He made pour-over coffee. He read the news with a focused, sometimes irritated attention. He had a long-running argument with his wife, Carla, about whether the kitchen radio should be on or off during dinner. She wanted it on. He wanted it off. They had been having this argument pleasantly for 11 years. They had 2 daughters, one in college, one in her last year of high school. By all measures, Daniel was unremarkable in the best possible sense. He was a man who had built something careful and livable and real. He was not naive. He was not reckless. He understood consequences. He felt shame when he made mistakes. He felt fear when his daughters were late coming home, when a student was struggling, when he saw something on the news that touched something old and protective in him. He was, in other words, a person in the full emotional sense, someone whose inner life was continuously shaped by signals from his environment, signals that told him what mattered, what to avoid, what to approach. He did not know those signals had a name. He did not know they were produced, moment to moment, by 2 small almond-shaped clusters of neurons buried deep in his temporal lobes. Nobody thinks about their amygdala, not until they have reason to. It began with a headache. That is how it begins for a great many catastrophic things, which is part of what makes catastrophe so disorienting. It arrives in ordinary packaging. Daniel had a headache on a Thursday. By Saturday, he had a fever. By Sunday, he was confused in a way that Carla could not dismiss, forgetting the middle of sentences, asking her the same questions twice, once looking at her with an expression she described later as simply blank, as though she were a stranger he was politely waiting to recognize. She drove him to the emergency department that evening. Within 48 hours, he was in the intensive care unit. The diagnosis was herpes simplex encephalitis, an infection of the brain caused by the herpes simplex virus, not uncommonly responsible for the most severe form of viral encephalitis seen in otherwise healthy adults. The virus has a particular affinity for the temporal lobes. It moves through neural tissue, inflaming and destroying as it spreads. Treatment, intravenous antiviral medication, was begun quickly. By medical standards, Daniel's outcome was considered good. He survived. He did not require mechanical ventilation for long. He was eventually transferred to a rehabilitation facility. His language came back, imperfect at first and then nearly normal. His memory for the distant past was largely intact. He could name his daughters. He could describe the school where he worked. He could hold a conversation. It was not until he came home, until he was back in the kitchen where he had made his coffee every morning for 11 years, that Carla began to understand that survival and recovery are not the same thing. The radio was on during dinner. He did not complain. She turned it off, waiting. He looked up, smiled at her, and said nothing. That was when she first knew. He had never once let that go without comment. The changes came into focus gradually, then all at once. The first week home, Carla noticed that Daniel would pick things up constantly, objects from the counter, items from shelves, and examine them with an intensity that seemed disconnected from any purpose. A rubber band, a pen cap, a measuring spoon. He handled them as though they were specimens. Once she came into the kitchen to find him holding a raw potato he had taken from the pantry, turning it slowly in his hands, bringing it close to his face. He was not going to cook it. He seemed to have simply needed to hold it. He began putting things in his mouth that were not food: a button from a drawer, a piece of tape from a package, a pencil. When she questioned him, he showed no embarrassment. He did not understand why she was concerned. The hyperorality, the clinicians would later confirm, was nearly textbook. The placidity was perhaps harder to live with than the behavioral changes, because it was the placidity that made Daniel feel most absent. He no longer reacted to things that should have provoked a reaction. Their younger daughter came home one evening upset about something that had happened at school, crying at the kitchen table. Daniel sat across from her and watched. He did not move toward her. He did not speak. He wore the same loose expression he wore watching television. Carla got up and held their daughter. Later, she would say that Daniel's face in that moment was the loneliest thing she had ever seen, not because he was suffering, but because he wasn't. He showed no recognition that something was required of him. The hypersexuality emerged within the first month, disinhibited commentary and behavior that bore no relationship to the man Carla had known. It was contextually inappropriate and distressing for their daughter to witness on one occasion, and Carla began quietly managing the household in ways she had never had to before, monitoring who was home, what conversations were happening, what Daniel had access to. She did not discuss this publicly. She carried it. In public settings, Daniel would sometimes approach strangers without the ordinary social buffer of hesitation, touching, speaking too closely, reaching for things that belonged to other people. He was not aggressive. He was never hostile. But he was no longer governed by the invisible social architecture that most of us never notice because it operates without effort. His fear was simply gone. In situations that should have provoked caution, a car approaching in a parking lot, a pan on the stove, he showed no adjustment of attention, no flinch, no register of danger. Carla found herself watching him the way you watch a child who does not yet understand the world is dangerous. What happened to Daniel has a precise neurological explanation, and that precision is, in its own way, unsettling, because it reveals how specifically located some of our most essential human qualities actually are. The amygdala is a paired structure, one in each hemisphere of the brain, located deep within the temporal lobe. It is not the seat of fear, as popular science sometimes oversimplifies it, but it is the brain's primary threat detection and emotional valuation system. Every time you walk into a room and sense something is wrong before you can articulate what, every time your body tightens before your mind catches up, every time you feel a reflexive aversion to something dangerous or disgusting or wrong, that is the amygdala doing its work. It assigns emotional significance to sensory input. It tells the rest of the brain what matters. It is also deeply connected to social cognition, to the recognition of emotional states in other faces, to the modulation of sexual behavior, to the regulation of approach and avoidance behaviors. The amygdala is what makes a human being's internal experience responsive to the external world. When both amygdalae are destroyed, as they were in Daniel's case by a virus moving bilaterally through his temporal lobes, the result is not simply emotional blunting. It is something more total. The mechanism by which stimuli acquire meaning is severed. Food and inedible objects become equivalent. Both are worthy of oral exploration because nothing signals danger. Strangers and intimates become functionally similar. Both are approached without the graduated caution that social fear produces. Dangerous situations and safe ones carry the same emotional weight, which is to say, none. The hyperorality, the hypersexuality, the placidity, the indiscriminate approach behavior, these are not new behaviors that the brain has invented. They are what remains when the system that regulated and inhibited these behaviors is no longer operating. What Kluver-Bucy Syndrome reveals, neurologically, is that what we call personality, the particular texture of a person's caution, their warmth, their disgust, their protectiveness, is not a ghost in the machine. It is the machine, and specific parts of it can be taken away. Daniel entered a long-term neurological rehabilitation program 8 months after his encephalitis diagnosis. There is no treatment for Kluver-Bucy syndrome in the way there is treatment for an infection or a tumor. No medication restores the amygdala once it is destroyed. Management focuses on behavioral structure, environmental modification, and in some cases, pharmacological reduction of specific symptoms such as hypersexuality or hyperorality. For Daniel, a combination of low-dose antipsychotic medication and a highly structured daily routine produced modest improvement in the most disruptive behaviors. The compulsive mouthing of objects became less frequent. The contextually inappropriate social behavior became more manageable with clear environmental limits. The placidity, the absence of fear, the emotional distance did not change. It is unlikely to. Carla continued to visit. She brought their younger daughter on some visits and made other decisions quietly about which aspects of Daniel's presentation their daughter should not have to navigate. She does not describe her situation in terms of grief, though grief is the clinical framework most often applied to families in her position. She describes it as a recalibration, a slow, effortful process of learning to love a person you no longer entirely recognize, within the limits of what that person can now offer. Daniel, for his part, is content. He smiles often. He handles objects with steady, absorbed attention. He sometimes talks about his students, his trails, his daughters. He does not miss what he has lost, because he does not know that it is gone. That, perhaps, is the detail that stays with you. We tend to think of ourselves as the choices we make, the relationships we build, the things we say, the way we move through the world. But Kluver-Bucy Syndrome suggests something more unsettling beneath that. It suggests that the self is also a set of constraints, the fears we carry, the disgust that stops us, the invisible hesitation before we act. Destroy those constraints, and a person does not become liberated. They become unreachable. Somewhere in the amygdala, filed alongside the fear of heights and the sound of a strange noise at night, is something that might be the architecture of a self. Daniel is still there, but something essential is missing, something he cannot name and does not mourn, because it is the very thing he would have needed in order to. If you like unsettling psychology, like and subscribe for a new diagnosis each week.